So hello everybody and welcome to our next session. I'm Gemma Chanatulika. I'm chair of the Board of Trustees at Cambridge Rare Disease Network. So welcome everybody to RAREfest22. It's my absolute pleasure to introduce this session which we've called Finding a Needle in a Haystack. So our speakers today are Amanda Pichini, who is the clinical lead for genetic counselling at Genomics England. She's working on a whole genome sequencing newborn screening pilot program. We also have Kate Downs down at the end. Kate is the scientific lead for rare disease at the East Genomic Laboratory Hub, which delivers the genetic and genomic testing for the NHS across the East Midlands and East of England. And we also have Peter Fish. Peter, there. Peter is the CEO of Mendelian, a company that has developed technology for primary care to enable faster diagnosis for people with rare and hard to diagnose conditions. So they're going to be guided through the conversation today by the hosts of the Genomics Unraveled podcast, who are Lydia Seed and Angela Lochmueller. Over to you, Lydia and Angela.
Thanks for that introduction, Gemma. So yeah, hi everyone, and welcome to this event called Finding the Needle in the Haystack. And I'm Lydia.
I'm Angela.
And today, with our expert panel here, we're going to explore various issues and challenges encountered along the diagnostic odyssey, starting from pre-diagnosis through to point of diagnosis and then post-diagnosis. And we're going to be guided by some pre-recorded interviews with mums who are part of Unique Feet, which is a community group within Cambridge Rare Disease Network, which I'm sure many of you are familiar with. And hopefully we'll have some time for some questions from the audience at the end as well. So to kick things off, let's have a listen to what Stacey and Kim had to say about the pre-diagnosis part of their journey.
Lois was very poorly when I was pregnant, so she's got a heart condition. So we weren't sure if we're kind of advised the pregnancy wouldn't reach full term and probably wouldn't be viable, and that she probably had something genetic going on, but we didn't have genetic testing during pregnancy. We thought, well, we'll find out whenever what happens.
That was very much out of the blue. It wasn't kind of a long drawn out process. She was a very healthy child. She's never had antibiotics. Was perfectly fit and well, and then at the end of 2018 she started being sick and just not herself. It went on for a few weeks. We went to the doctor and they said, I think it's just gastro, see how she is. But literally was waking up every morning and trying to be sick, and there was nothing there. She couldn't. Then she started getting pains in her legs and her stomach. She couldn't walk. She had to be carried through school. So I went back to the doctor and I was like, look, it's not gastro. Can we? And he's like, straight away, no, it's fine. We'll do a blood test. So they did a blood test. And a few days later, rung me and was like, you need to bring her in now. So went to school, got her, drove to the hospital. They said her salt and potassium levels were really low, so they just needed to put her on a drip. They did that. And then about 2 hours later, she was in ICU. And basically her whole system was shutting down.
So thank you to the mums who shared their stories there. So we heard two very different experiences of the pre-diagnostic journey. And we'd like to go first to Peter and ask about how Mendelian, your company, is improving the pre-diagnostic journey.
Thanks very much. So at Mendelian, we focused on shortening that diagnostic odyssey. In fact, surfacing patients where rare diseases are not yet technically possibly even called undiagnosed. They unsuspected, so where clinicians have no indication that this could be a rare disease. Situations where patients are presenting with different signs, different systems that clinicians generally wouldn't join the dots together because they don't know these diseases, etc. We work and help clinics and GP practices or even large population groups to look through all of their patient population, scan all of their electronic records, and identify patients who are showing early patterns of progressive rare diseases. And we surface those patients up to the clinicians in those areas, and they then, we give a lot of information about the patient and the diseases. They then use their own clinical judgment to decide how to put those patients forward within, in this case, within the NHS. So ideally, really trying to join the dots between these symptoms and pictures that these patients present with, that no one really has the time or the knowledge to be able to figure out that this should be a patient that should be tested for a particular disease.
So for a mum like Kim, who was the second mum who spoke, that could have kind of shortened her diagnostic odyssey, per se. Could you give an example of kind of a disease where that would have...
Yeah, great. We have a great disease that we're working on at the moment called XLH, and I've spoken to a few people about this morning already, but these patients present with rickets quite early on, and they have abnormalities in their phosphates, etc. And quite typically, primary care, when you see rickets, they diagnose it as nutritional rickets. And it turns out, in fact, in the UK, nutritional rickets is less common than the rare disease that causes rickets, XLH. So there's a huge amount of these patients that we're seeing and flagging up to the clinicians with rickets in their electronic records and some phosphate abnormalities that we're putting forward. And in fact, of the 11 or so patients we've flagged in the last 6 months, almost all of them are starting to move forward towards testing, which is great. And in fact, in this case, there's a treatment for this disease, and the earlier you start this treatment, the better the outcomes are.
It's a great success story. Great. And if we move on to Amanda, do you have any thoughts about this pre-diagnostic journey specifically to do with the work that you're doing?
Yes, thank you. So at Genomics England, one of the projects I'm working on is the Newborn Genomes Programme, which aims to sequence the genomes of up to 100,000 newborn babies who don't have necessarily a prior history or family history of a rare condition. And one of the goals of that really is to take that pre-diagnosis journey right back to the very beginning before symptoms even start. So thinking about the story that Kim shared, and without knowing exactly what condition that is, the hope is that we can find conditions like that where there is some kind of treatment or intervention that we might be able to put in place before symptoms even begin, and aim to do that by identifying what those genetic changes might be from birth. So we're kind of taking that diagnostic odyssey out from the beginning. As many of us know, every baby in the UK has a heel prick test at birth that looks for 9 conditions with that aim. But the hope is that by doing whole genome sequencing, we can look for specific changes in genes that we know there might be some treatment at play, and think about whether we might use that as a technology to expand the number of conditions that we look for in the newborn period. So that's what we hope to understand by doing that research study.
Cool. And what can we kind of what's the timeline of the study at the moment?
So at the moment, we're hoping to start rolling out this study later next year. It's a long phase of engagement and design that we've been undertaking over the last couple of years, because this is quite a big project, and it's not something where we're starting with families that have prior knowledge and history and investment in many ways in a rare condition. We're talking to parents who are going through pregnancy with many other questions and concerns that they might have. So what is it about this kind of study that would make them interested to take part, given a relative minority of those 100,000 babies will actually go on to have one of these rare conditions? So we've been doing a lot of engagement with the public, with members of the rare disease community to understand, well, what are your needs in terms of the diagnostic odysseys that you go on that we might be able to change? And there's a lot of ethical issues to consider as well when we're doing something like genome sequencing in a newborn baby where their parents are providing that consent on their behalf. We need to make sure that we're treating that data very safely and respectfully, and that we're being careful about the kinds of changes that we're looking for, so that we're not, we're very careful about things like over-medicalization or over-diagnosis, or things that might shift the way that we look at health and disease, but that we can really focus on that aim of identifying more babies who could access that earlier treatment when they need it.
Thank you. So I think we'll move on to the next point of diagnosis, and the next video from our mums.
So then when she was born, we had the genetic testing then, so they took the blood from the placenta, and she was also part of the Next Generation Children's Project. So we had our genetic results really early. Within a few weeks of her being born, they said oh, we don't really know anything about it, it's rare, it's unique to her. So here's some things we do know about other children who've got conditions around this area. So I was like, well, you've given us an answer, but not really an answer. I did reflect on this at some point, and I thought, actually, at the time she was in intensive care, she was quite poorly, and then we were given this genetic diagnosis in the middle of that, and I was just like, that wasn't the right time. And they said, actually, the reason we do it at that stage is because that can inform care, but in hindsight, actually, it was the most appropriate time for us to be able to move forward, make decisions. And that's very much what happened immediately. People were like, well, we need to check this, this, and this. Yeah. And we're in the right place.
Great. So, Kate, I'd like to come to you. Stacey mentioned the Next Generation Children's Project there in that video. Could you tell us a little bit more about this project and why rapid genetic testing in neonatal ICU settings is so valuable?
Yeah, I can. So the Next Generation Children's Project was a project run out of Cambridge, and it's really had two great impacts. Firstly, some of the patients and the families of those patients got a diagnosis from that study. So this was rapid whole genome sequencing of these babies that are really sick in ICU or in NICU, so neonate ICU and pediatric ICU. So one of the things that was learned from this project, that when you have a really sick baby, you often don't know, the doctors don't know what's wrong with that baby. They look like a baby. They might have lots of things going on. They might have secondary things going on. Levels of blood proteins might be different because they're newborn. And sometimes features that we recognize as associated with some genetic conditions might not develop until that child is older. So the genetic diagnosis done really rapidly at that point can really pinpoint what's wrong with that child. And as Stacey said, can start to inform on treatment or specialist care. So if a patient's got a certain condition, then maybe they need to be seen by specific consultants or different consultants. So that was one way that the Next Generation Children's Project has really helped us understand how rapid whole genome sequencing can help these patients and their families. The second thing is that really led to the evidence that shows that we should be doing this in the NHS. And so now, not as a research project, but as an NHS commissioned service, rapid whole genome sequencing is now available to children in NICU PICU. And so this is a great example of where research and a concentrated effort in one part of the country then leads to a widespread adoption of a service that's helping lots of children and their families across the country.
That's a fantastic story. And so then, taking that and going kind of one step further and going back to what Stacey was saying, sort of about the right time for this diagnosis. So she mentioned that clinically this was the right time to be able to make informed decisions, but perhaps not emotionally the right time. This is, with the rollout of that service nationwide, this is going to be a clinical dilemma that lots of clinical teams are newly facing a lot more commonly. What sort of advice would you have, and how do you think that those issues are best tackled?
So I think I'm probably the wrong person to ask about this. I'm a clinical scientist, and Amanda's background as a counsellor. So I think there is that juxtaposition between providing that diagnosis really early to help, but also that emotional time that a mum, I'm not a mum, and I've never had a child in ICU or PICU, and that must be a really difficult time with lots of emotions, not only because the child's not unwell. So I think that I understand, I think we can all understand how confusing and how lots of information is given to a parent at that time. I don't know if, Amanda, have you got...
Yeah, so as a genetic counsellor, I was involved in seeing some of these families, not through the Cambridge study, but as we started doing this in the NHS. And it's as you said, a really challenging time when you're not a parent that's had a very long diagnostic odyssey, but you're really hit with that information quite critically at an early stage in baby's life, or like in Stacey's case, when it comes up maybe out of the blue in a pregnancy. I think it's really important that we make sure that there's supports ready for those families when we know that's going to happen. And that's not just dependent on the genetic tests. There may be other tests that Stacey's daughter was going through, but the fact that she had a lot of things going on with her health meant that she needed that support. So to me, that means it's not just having genetic counselors involved that can help explain the implications of the test and be there more after that diagnosis is given, when they have that journey of adaptation that hopefully led Stacey to the position where she felt actually in hindsight it was the right time to do it, but at the time it was really distressing. That's understandable. But we also have to make sure that the neonatologists, the nurse specialists, the midwives, the health visitors, who are very good at communicating with patients about lots of very difficult things, also understand the challenges that maybe genetic testing or rare disease can bring to that journey, and that they're also there to be able to provide some of that support. That's not just down to the counselors, it has to be the whole kind of multidisciplinary team that's able to recognize when families are struggling and what's their role in being able to support them or signpost them to more specialist support when they need it.
That leads us really nicely on to our next slide. So that will be about post-diagnosis and how we communicate around that.
I do think one of the downsides is that because I think this is an interesting thing, because I think a lot of people who wait years and years for genetic condition feel let down and lost, and they know it's genetic, but they don't know what it is, and then people don't know how to, signpost them. But actually, for us having our genetic condition so early on, it now means that everything's contributed to Lois's genetic condition when, and then they're like, oh, well, there's no point in doing something because it's probably part of her condition, and children with genetic conditions can be like that, rather than thinking, well, actually, we'll investigate it. It probably is part of her genetic condition, but let's see if we can make it better.
It was quite stressful because we were still kind of learning about her diagnosis, sort of understanding it. And, we were sort of unsure because a lot of the time they didn't know how things would affect her, because it's very rare in children. So there's not a lot of evidence there.
Okay, so for our final section, we'll be asking all of the panelists about their views, and also the audience at the end. So if you're feeling brave, then we'll have a Q&A at the end. But as the mums spoke about, the diagnosis isn't the end of the journey, and we'd like to ask you about how, as individuals and also as a healthcare service, how we can better support these families post-diagnosis. So whoever would like to start, maybe Kate.
Okay, so I think Stacey recognising that clinicians are sometimes lumping everything that's wrong with her child as associated with this rare condition, and really struggling with that is an issue. And I think a patient with a person with a rare condition is a person, and like the rest of us has infections and broken legs and muscle strains and all kinds of things going on. So I think it's really important that that we make sure that doctors and healthcare professionals understand that. I think there's several ways that we can do that as a community. So we have days like this to raise awareness about rare conditions. And Amanda and I and Peter talk to lots of people like you, but also we do lots of education events to make sure people are aware of the range of different rare conditions. So hopefully that will start to make people aware that people with rare conditions are people, but also that there's such a difference in the type of symptoms that people with rare conditions have. I know that there's lots of work going into changing how the genomic syllabus is taught in medical school, which is great. And Amanda and I specifically go around and spend a lot of time teaching healthcare professionals how to order genomic tests and about genomic testing. So I think that there's a whole load of things that we can do to make sure that we drive awareness and understanding of rare disorders within our community.
So I agree fully, but I'd say, in the interim, as we start evolving medicine, the patient advocacy groups are really, really supportive, and often when we talk about the impact of a diagnosis, the positives that come out of it is being connected into a group that is, you can identify with and travel that journey with. I think looking at medicine and how we're trying to change medicine, the evolution of specifically in primary care, looking at common diseases and kind of ignoring the rare diseases just because you couldn't really deal with them and diagnose them, that's changing. And in fact, we see medicine evolving from every common disease just getting stratified and stratified down into smaller diseases and becoming rare independently. And traditional medicine wasn't set up for that. The pattern matching wasn't good enough. As a doctor, you didn't know the patterns, and you have to facilitate that, we think, with some information technology and bringing that information to the right place at the right time. And I think we'll see a transition in the way medicine is run. I think doctors were traditionally scared of rare diseases, but in fact, it's a false sense of reality thinking that a patient with a common disease, you can lump them in one way and treat them in one way, because they're all independent, they're all individual, and they don't respond like you think they might. So I think doctors will realize and become more comfortable with this. I think one fact that I have spoken about today, 50% of the drugs approved by the FDA last year were rare disease drugs. So clinical medicine is moving largely in this, not yet personalized, but stratified direction. I think doctors in time will come aboard.
I think Peter and Kate made some excellent points, and I agree in particular that I think the healthcare professional workforce is shifting. We see that a lot in cancer care as well, where we're not just seeing it so much as breast cancer or bowel cancer, but there's so much more stratification of treatments that people are recognizing that often these are more than just one disease. So we can hopefully apply that to the area of rare conditions in other areas as well. And I think that's starting to shift and that's starting to happen. The other thing that really resonated with me from what those mums said is I think often parents look for a bit of acknowledgement and validation that there's a lot being put on them at the time of a new diagnosis, and it's okay for that to take a little bit of time to settle in. There's often a sense of, right, I am this child's parent, so I've got to just get on with things and figure out what to do. But when you have a very rare condition and it's often quite isolating and there aren't many other people to turn to, that's not easy. But it's probably normal that that isn't easy. I don't think that would be easy for almost anyone. And often I think sometimes what parents are looking for is a little bit of a acknowledgement that this will take some time. How are you coping with this? Who are your supports in your support system? Not all mums deal with it the same way. Dads deal with it in very different ways as well. And we often aren't able to necessarily cater to those different needs that people might have, whether that's, I'd like to be connected with a patient support group now, or actually that's way too early for me because speaking to other people would really freak me out. I need a little bit of time to come to terms with it myself and with my family before I'm ready to reach out to other people. So I think we have to recognize that post-diagnostic journey has its other twists and turns, and that involves working with other healthcare professionals and also just acknowledging that that's going to take some time. But we see how those parents come to that process of adaptation over time, and that's just different for everyone.
Fantastic. Thank you very much, all three, for those really interesting and thought-provoking answers. We've got about 5 minutes left to take some questions from the audience, if anyone wants to be brave.
Thank you. I'm Nigel Over. I've got a 25-year-old son with Smith-Magenis syndrome. I'm also CEO of the SMS Foundation. Now, where we are with technology, it's an exciting time. We're talking about diagnosis at birth and genetic sequencing. We've heard from Peter about a database of symptoms that can be aligned to what's understood from parent organisations. What hasn't been mentioned is something that NHS England are now starting on, which is pharmacogenomics as well. Now, with all of this understanding coming forward, are we now coming to this stage where we can do basically the Gattaca question, a pinprick test at birth that defines what medical interventions could be brought in and when, based on symptoms being shown pertinent to a genetic disorder, to do a lifelong pathway for interventions, say for my son when he comes 25, and avoid all of the pains of trial and errors, conflicts of medications, so that we actually get a really good understanding. But from possibly Amanda's perspective, what is the risk of that actually then parents becoming hypochondriacs and looking for those symptoms based on the diagnosis? So it's quite a big question, but it'll be interesting to hear what your views are, and you're all nodding.
I can go first. I think you've just very accurately reflected what some of the dilemmas are when we deal with genetics like any new technology. There is often no just benefit to using it. It's how it's used that's really what's important. I don't have the answer to your question. I don't know if anyone else in this room does, but I think it's probably safe enough to say that what's important is that we are having these discussions out in the open and that we're able to surface what some of these ethical concerns might be, whether they are very realistic or not realistic, but we need to be thinking about them for the future. We know that genetics doesn't define everyone in its entirety. It's not the whole story. It's never going to be the whole story, even as we learn a lot more about it. And that's, I think, a really important distinction to make, that we're not going to see someone's genome and be able to tell everything about them just on that basis. I don't think we'll ever be there. But there may be some positives we can glean from that, like being able to have, preemptive treatment, preemptive intervention, rather than having families having to go around the houses searching for those answers. So I think it's just using research to try and explore how we can extract the benefits whilst analysing, mitigating, and discussing what those possible harms might be.
Yeah, I'll make one or two comments. I think actually Genomics England has a very good example of playing this out in reality. The 100,000 Genome Project was very ambitious, but everyone said, what about all of these things that could transpire that were negative? And ultimately, when you as an example with Mendelian, we've now brought this medical device through and it's rolled out into practice. It's often, you can do so much research and you know that there's going to be some risk, but you know that there's a significant benefit that you could unlock with these things. And in these cases, the best approach often is to roll it out in a gentle way and monitor very closely. I know with your stuff, which is very novel and very exciting, world first, it's going to probably go down the same route. You roll it out and you look very carefully. You handle everything with a good deal of care. Look after the people that are in there, and ultimately, you're really trying to just make sure you're delivering much more benefit than any of the negatives that happen. There will be some things that are negative, but let's hope that the positives will far outweigh that.
So I'll just be really quick because I know other people want to answer questions, but I promise pharmacogenomics is coming. It's really exciting. We're already doing some pharmacogenomics within the NHS, within the new Genomic Medicine Service. So for those of you who don't know, pharmacogenomics is where we look for genetic variants in people that change how we respond to certain drugs. So you can tailor dosage of drugs or not give a certain drug to somebody based on some of their genetic information. I think this is going to be something that we all hear a lot more about over the coming years, and I'm really excited that that's happening. Next time we're here, I can tell you more, hopefully.
Hi, that is a fantastic panel. I'm Emma. I'm a Chief Patient Officer at Ipsen Biopharma. And I just want to respond, I think, to, as a follow-on, really, from the previous question and my own question, if I may. So I'm new in post, so I've spent 26 years working with patient organisations. So I stepped over to the dark side of pharma on November the 1st. And that's been massive learning for me. Now, Ipsen has a drug that's just going through FDA approval for FOP, fibrodysplasia ossificans progressiva, which is basically where bone grows in connective tissue. And I joined Ipsen quite cock-a-hoop, thinking these drugs are coming through. And Ipsen just did a fantastic burden of illness study to verify to various healthcare authorities the impact of taking care of a child and a person with FOP. So it was quite staggering to me when heads of these patient groups said, we don't perceive our child as a burden. So actually, even the term burden of illness study is quite offensive. So I'm just wondering where we go. We are focused on creating medicines and bringing things through for people, which is what we should do. But I wonder if we lose sight of that communication piece and that care aspect. So that's my statement, and I'd like to invite comments from, do we as clinicians, as researchers, lose track of those basic emotional support needs for people? And I'd like your opinions on that. And the second part of that is to what you just said there in terms of pharmacogenomics. We have a communication responsibility, don't we, in terms of the literacy around that. So if we look at cystic fibrosis, which is actually 118 genetic mutations that lead to a diagnosis of cystic fibrosis, the drugs to treat cystic fibrosis only work for 9% of that genomic makeup. So I think, again, it's that communication responsibility that people, parents, come to us and they're looking for us to give them hope. And perhaps we're not listening to that bit. So there's two parts to that. What role do we have in that communication piece? And what role do we also have in not, remaining scientific so that we're not giving false hope to people?
That's a big question, isn't it? So I think you're right. I think you're right. We as healthcare professionals, and me as a clinical scientist myself, is often very focused on that scientific side of things and the diagnosis. I'm really glad that we work with counsellors and with clinical geneticists alongside, and our departments are right next to each other in Addenbrooke's in Cambridge, so we really get to see the whole picture most of the time. So I do take that comment, and I think as part of my practice, I try and make sure that I remember all the time that there's a patient at the end of those scientific results, and that affects the research that I'm involved in and the clinical diagnoses that I provide. I think Peter said something really interesting, and I didn't quite know this, that half of the FDA-approved drugs are for rare diseases. I think around thinking about pharmacogenomics and rare disease, we are in a really tough space at the moment where pharma and research and industry are all working together, and of course the focus at the moment is on more common rare conditions. And I think that over the next 5 years, then hopefully the information that's generated from the development of those treatments will then start to filter down to even more, rare conditions. So patients like Stacey's, who has a really unique condition, perhaps only a few people in the world are affected, they can start to be treated as well. So I think we're in this really interim period, in this melting pot of science, and where we're really trying our hardest to provide treatments, but only to a certain population, as you said.
I think that's absolutely right. I think one of the dangers with the excitement of genomic technology is it is just that excitement without managing some of those expectations that there are uncertainties. And that's fine. That's why we're doing research. That's why we're still learning. We just have to be honest about what those uncertainties are. And as you said yourself, families may or may not see any kind of burden there, but they all want hope. They all ultimately want their child to be able to live their best life. So it's okay to be able to think about what those interventions might do to help facilitate them do that, whether or not they see it as any burden in any way or not. That's the crux of what's happening. I think there are better ways that we can communicate, particularly when it comes to, especially families with rare diseases. They might often only have a few very scientific graph and technically full papers that they can read and access. That's not a great way to saying, well, what am I getting out of this that's helpful for me? There's lots of things that we can do to improve communication, but on a basic level, I think those simple messages about managing uncertainty is just something we constantly have to be saying.
Yeah, thank you, Emma. I'll also answer a few questions on that one. And actually, we work with FOP and Ipsen very closely. Yeah, we'll chat afterwards. What we've seen actually in the last while is exactly what you're talking about, is this the disconnection between patients and the health setting. I mean, it's for us justifying. All of you in this room will realize how difficult it is to justify anything with rare diseases to a health setting. And we've had to bend our language on what we use to speak the language of what they understand. So words like burden is something that health economists use and the NHS use quite frequently. But I think that the platforms like that Cambridge Rare Disease Network gives and these types of things that allows these patient populations to have a voice and make a change is incredibly valuable. I think another piece really connected to that is the only way we can make change in the rare disease space is by aggregating our voices, because we are the long tail of diseases and we have to be together to make an impact. I mean, that's one of the things we do when we deploy into any NHS setting. We deploy multiple diseases so that the combined prevalence actually makes a tangible difference for the setting. That makes it very tangible. Each individual is very tangible to themselves, but you have to aggregate in order to make that sort of population level change.
All right, well, I just want to really thank our panelists, Kate, Peter and Amanda. I think we could have carried on the discussion. We're already over time. I think we could carry on for quite a lot longer on this discussion. There's so much to talk about. And thank you to our hosts, Lydia and Angela as well.